Welcome to the Doctors Hospital Distinguished Lecture Series. Every month we invite members of our medical community to speak on topics that matter to you, the Bahamian public. We trust that you will find this information useful. Now sit back, listen, and learn. Isn't your health worth it?
Gout. What is gout? It is a disease or condition rather where the body mishandles or accumulates a compound called uric acid. And this uric acid accumulates, and in a certain segment of the population it deposits in the tissue, and the body's response to the deposition of this crystal is what gives you the clinical condition, the symptoms and the signs of the disease. So gout is the most common inflammatory arthritis in men. It affects 1 to 2% of men in Western countries. It also affects women, but it's more common in men. The incidence or the prevalence of gout has increased over the past several decades. It's an old condition. It's been around for centuries, but it has been influenced by the quote-unquote Western diet and lifestyle, of which we are big partakers. Notably, only 2% of patients in the United States are with gout actually treated by rheumatologists, probably the same percentage here, and hence you get the cyclical pain resolution but gradual progression of the condition, which is in today's world essentially unnecessary. So why is gout becoming more prevalent? The conditions which predispose to gout, which are associated with gout, are being better treated, and patients are surviving longer. And these are conditions such as congestive heart failure, chronic kidney disease. Furthermore, conditions which predispose to these conditions are actually also becoming more common, such as hypertension and diabetes, obesity, and the metabolic syndrome. And so this complex of conditions which are associative and in some instances causative are becoming more prevalent, and so they're rising the gout. The incidence of gout is increasing along with the incidence of these conditions. So what is uric acid? You hear me talk about uric acid a lot. Uric acid is a compound that is a breakdown product of the body's DNA. There's a compound called purine that is a part of all of our DNA. And this breakdown product, uric acid, accumulates in the body. Primates and other mammals can break down the uric acid. They possess an enzyme which breaks it down. However, we possess the gene for the enzyme, but it's not active. And so this uric acid accumulates in the body. And here's just a schematic to represent the enzyme, essentially uric acid being broken down into the soluble product allantoin. But the uric acid accumulates in humans, leading to a condition called hyperuricemia. And this accumulation of uric acid is what predisposes you to gout. It's necessary for the development of gout. Multiple people will have hyperuricemia, or elevations of the uric acid in their body. You will go to the lab, you do your physical, your SMAC 25, you're fasting. I know everybody loves to fast. And you get your lab, and they say your uric acid is elevated. And that's actually very common, but not everybody who has uric acid obviously will get gout. But you need to have an elevated uric acid to develop the condition. Now, if you could think of, everybody here makes tea, correct? A lot of tea drinkers here, this is Bahamas, right? So everybody makes tea. You know, when you make your tea, you put in the 2 teaspoons of sugar, whether you're a lime or milk person, and at the bottom of your tea, no matter what happens, if you're putting in your sugar, when you get right down to the bottom, you notice that some sugar left at the bottom. And the uric acid is like that. Our bodies are mostly water, and uric acid, the compound that causes the gout, is not very soluble. It doesn't dissolve well. And so you could just imagine your body just accumulating these crystals of uric acid over time, and they would cause the problem. And so the level of uric acid in your body that becomes problematic is about 6.8 milligrams per deciliter that's the level at which this uric acid is insoluble and starts to come out of the solution of your blood and your tissue fluids and starts to accumulate in the tissues of your body. All right, in men, the level of the uric acid increases after puberty, but in women, starts to increase after menopause, which is why it's more common in men than in women, because men have the elevated uric acid level for much longer. And so there are 3 stages of gout. There's the asymptomatic hyperuricemia, where the level of uric acid is elevated, and that's necessary for a while before the person actually becomes symptomatic. Then what we call, there's acute gout, which we'll talk about, and then you have the advanced gout, which multiple facets too, which we'll also talk about later. So what we want to illustrate here is that if you look at the graph, the uric acid level, we talked about 6.8 being the level at which we start to get into trouble. Now, this is the amount of people who have gout with a certain uric acid concentration. And if you look at people with uric acid levels of 9 milligrams per deciliter or more, after 5 years, 1/4 of these people will develop gout. And you're talking about a common abnormality, so that's millions of people, that's lots of people with gout. And then as the level gets lower, the percentage drops, obviously. So gout is essentially a lifetime disease, a lifestyle disease. Some people get it because of conditions that they may have, but generally speaking, there are things that we do in our diet that really drive the development of hyperuricemia, which then tips us into gout. Now, for us in the Bahamas, this is particularly problematic because one of the things that increases your risk of developing hyperuricemia and gout is seafood. So we are 700 islands surrounded by sea. We like our fish, we like our conch, and here you go, there the problem lies. And then also red meats will also increase your risk of gout. Organ meats, for those of you who like your liver, that will do it. And obviously, we sweet them out. You have the Coca-Cola, the Pepsi, your sodas, the high fructose corn syrup, and you've heard a lot about that. That drives gout as well. And alcohol consumption. So 1 or 2 collects in the evening, set yourself up. And when we say 1 or 2, we know we're underestimating. There's good news though. Low-fat dairy products can actually reduce your risk of developing gout. So there are things that you can do that push you to or from developing gout. Now, this is an illustration of over time, the sugar consumption over the last century in the United States. So we have the sugar consumption and the sharp rise develops with the use of sodas, the not the high fructose corn syrup, but the sweet drinks. And then at around 1950 or so, that really picks up and the level of gout rises sharply. So you have the dietary habit changing and hence the development of gout or the incidence of gout increasing. Not that it wasn't there before, but the lifestyle and the sugar consumption contributing significantly to the rise in the incidence of gout. As far as the things you should avoid, organ meats and liver, kidney, like we say, sweetbreads, red meat and seafood you should definitely limit, and non-fat or low-fat dairy food you can encourage, actually. For, like we said before, the high fructose corn syrup, that's bad for you, but even naturally sweetened beverages and table sugar should be limited in patients who have gout. Now, in terms of alcohol, sorry ladies, but men, more than 2 drinks is considered overuse, but for ladies, there's one more than 1. So men get to have 1 more drink. Now, there are certain medications that are common, but also increase the level of uric acid. Lots of people have risk factors for heart disease, and so they're on low-dose aspirin, but ironically that increases your uric acid. But lots of patients with heart trouble or fluid retention for various reasons are on water tablets or diuretics. So they're on water tablets, but these water tablets also drive up the uric acid. and then laxative abuse will also do it. So some of the medical conditions, ironically, which will on their own increase your risk of gout, the treatment of those increase your risk of gout. So in these patients, you see a high occurrence of gout. It's not uncommon patients to be admitted to hospital with heart failure and then develop gout. So the clinical presentation. Gout is probably one of the, if not the most painful inflammatory arthritis. Usually it starts at one joint, and classically it's the big toe. We call it podagra, the joint at the base of the big toe. That one joint, overnight, rapidly within a day, becoming extremely painful. So painful that even the sheet sliding over it will drive the person insane with pain. It's very painful. And again, usually that's how it presents in most of the patients. And here's an example of the podagra. You get that red, swollen joint compared to the other joint. And just again, just rubbing your finger over it, the patient is up. It's very painful. Now, again, the attacks occur usually at night in the distal extremity, the lower limb. It's thought that that's because of that's where the blood is coolest, and that's the coolest time, and that's the furthest away from the heart. And so that's a perfect setup for a person who has a high level of uric acid in their body to develop the crystals, come out of solution, and cause the gout attacks. And as we said before, it's exquisitely painful, and the joint is very tender. Now, the attacks generally last anywhere from 3 to 10 days, and even if they're not treated, they tend to go away on their own. However, treatment shortens the duration of the attack. Now, usually gout it starts off in the big toe, but it's more common in the joints of the lower limb. The big toe itself, the arch of the foot at the top, the heel, the knee. It can present in the elbow as well, but initial attacks are usually in the lower limb. And it can also accumulate in tissues like an infection. It can present like a cellulitis. Patients can develop gout in their soft tissue, but they can also develop swellings in what you call bursa, collections of mucosal membranes that facilitate movement throughout the body, like in the elbow. That's called the olecranon bursa, and that's full of inflammatory fluid. You can also get it at the knee. Another example, the prepatellar bursa, full with inflammatory fluid. The attacks usually follow years of hyperuricemia. We talk about how you treat or if you treat hyperuricemia, but the patient has hyperuricemia for a while, and they usually develop their first attack in their 30s to 40s. Females a bit later, like we said before. And what happens essentially, the body develops a gout. So this is a schematic. That's your knee, or that could be any joint. And aligning any of these joints, you have the cartilage or the soft tissue. And what happens is the uric acid accumulates and starts to form these deposits. And these deposits are called tophi or microtophi, whether they're inside or outside the body. So they form there, but that in and of itself isn't painful. That can be happening inside you and you don't know. You can have multiple deposits such as this. However, certain conditions may arise, whereas, for example, you have a sharp rise in your level of uric acid, change your diet, change the hydration status, trauma, just simply striking it in a person with gout can do it. And what happens is the tophi, these deposits of crystals, become unstable. And they spray little crystals into the joint spaces. And it's the body's reaction to these crystals that cause the problem, as we'll illustrate later. And so what happens is the synovial fluid, the cells then migrate into the fluid where the crystals are and try to consume them, and therein you get your problem. So this is a real picture of somebody's joint, of a knee, and on the surface that's the normal healthy lining. And here you see the tophi, collections of the uric acid crystals. So that's a camera inside the knee looking at the joint, and you see the crystals there ready to form. Now that in and of itself doesn't cause you pain. That's the setup for the pain. And when those crystals get set loose into the body, this is what they look like under the microscope. So these are the thousands of little crystals. Those are crystals depending on which way they're oriented. And the body, these crystals get released, and then the body tries to destroy these crystals. It sends out its white blood cells to protect itself. And what you see is the cells consuming the crystals. So those are white blood cells. Those are part of your immune system trying to protect your body from this from the substance. And they consume it, but the crystal, as you can see, is sharp and large. It actually kills the cells. And when the cells are destroyed, their powerful digestive enzymes are released into the body, and that causes the pain. So the crystals themselves don't cause the pain, it's your response that causes the pain. And what happens is your body detects these crystals, sends out its army of cells to destroy them, and the casualties of war, the blood cells that die doing their duty, release their internal contents, and that is painful. And that is why you get a gout attack. And so the ideal way to diagnose gout, if we can step back for a minute, is to actually look at the fluid and demonstrate these cells under a microscope. That demonstrates that you have gout, proves it. But that's not always possible. Sometimes the attack is already resolved, and you go to the doctor and it's already happened. And so there's the American College of Rheumatology and the European League Against Rheumatism in 2015 developed some classification criteria to help us to characterize typical gout attacks and just see if we can classify patients as having gout. To just basically what's the likelihood that what the patient had was gout. And there are certain things that increase your risk. That first toe, a metatarsophalangeal joint, that gives you a lot of points relative to other joints. Whether or not you had a typical joint attack, which was maximum, will increase your risk of having points. For example, you have can't touch the toe, difficulty walking on the joint, erythema of the overlying skin. You have all of these characteristics together that increases your probability. And the more points you accumulate from a typical attack, the more evidence you have, the more likely it is that you have gout. Other notable points in your favor, if your uric acid is between 6 to 8, then that gives you 2 points, and higher uric acid level, the more points you get. Obviously, if you demonstrate the crystals, like we say, that gives you a lot of points. And if you have imaging suggestive of having gout on ultrasound or x-ray, then that increases your probability. So how do you treat a patient with gout? What we want to do is lifestyle modification. Check your risk factors. If your uric acid is elevated, there are certain associations you may have. Is this patient diabetic, hypertensive? Look for those risk factors, modify them, but we don't actually treat the uric acid just because it's high. Reason being, most of these patients won't develop gout. You need that to develop gout, but not every patient with it will. So you don't treat every patient, you don't treat it. Now, you want to eliminate possible causes and, again, manage the risk. So in the event that the patient develops gout, and it's a typical attack, it's in the toe or in the lower limb, and it's suspicious for gout, how do you treat? Now, the gout is best treated early. The earlier you treat it, the more effective your treatment is going to be, and the shorter the duration of the attack. If you treat it within several hours, within the first 24 hours, regardless of which method you use, you are better off. The attack will be shorter, and the treatment will be more effective. What you want to do is to stop that cycle of the cells coming in and getting destroyed. You stop that as quickly as you can, and you're better off clinically, but you get a better result. Now, the medications that we can use to treat gout, there's a very old medicine called colchicine. Basically, that stops the cells from coming out into the tissue, stops them from going out to crystals. And the earlier you institute this treatment, the better. There are the common medications called like the Aleve, the ibuprofen, indomethacin. You can use these medications as well. they also stop the inflammation. But in patients, for example, who have risk factors such as kidney failure or chronic kidney disease or heart disease, where these medications are not necessarily safe or the best choice, you can use either oral steroids or you can use intra-articular steroids, meaning you inject the joints that are affected. And if the attack is particularly resilient, you can use combination therapy. But the attacks, like I say, are best regardless of the agent. Best results are recognizing it and treating it early. The higher you treat, the more effectively you treat the uric acid, the lower the frequency of gout attacks you will have. Now, the individual, most people who have a gout attack will have another attack within the next year or two. It is not every patient will, but once you get one gout attack, you're more likely to have another. And after you are hyperuricemic for years, the more frequent the attacks become. And basically, it becomes a cycle. The patients generally, it's from my experience, they get an attack, they have the elevated uric acid, they treat the attack, and because the attacks are not frequent initially, they don't seek care. They don't seek to manage the gout properly, as we will discuss later. And what happens is they get into a cycle, and by the time they are looking for treatment, they have what's called advanced gout, where they have multiple attacks, or there's no pain-free interval between the attacks. They just constantly painful, or they have so much uric acid accumulating in their body, it begins to give them deformities, and they start to look like patients that have rheumatoid arthritis, because the two are clinically indistinguishable in terms of with the way they look. And so you get the advanced gout, you get the development of what's called tophi, you lose any pain-free period, or the attacks become long and it can last up to several weeks. And so what you want to do ultimately is to, in addition to treating the acute attack, you want to treat the elevated uric acid. So what you have here are examples of tophi. These are collections of uric acid now depositing in the skin. See, there you see them in the ear, the fingers and the ears. They are internally already, but now they're starting to manifest externally, at which point the diagnosis is readily apparent. And these are another evidence of tophi. All of that is literally uric acid depositing in the skin. The patient has so much uric acid, it's just starting to deposit wherever it will. And there you get the tophaceous gout that we talked about, the advanced gout, where there's so much uric acid in the body, it's actually starting to give these deformities. All of that is uric acid, just accumulating. And the more you accumulate, the more it builds up and deposits. It can actually give you a destructive and disabling arthritis. So it's not a simple and a benign condition in the advanced stage. And this can happen to patients with gout. Completely unnecessary. And there you see the gout actually destroying the bones. These pale areas, that's where the uric acid deposits are. This swelling and deformity is completely destroying these joints. So what do we do to treat the gout? How do we treat? After we treated the pain, once you have developed clinical gout, the arthritis, then your uric acid level needs to come down. That actually doesn't treat your pain, however. And this is the key to the discordance, and where you get the difficulty, where the patients simply don't understand the difference between treating their uric acid level and treating their pain. And it can cause multiple problems, because the treatment of the uric acid and using the medications that bring the uric acid down actually can cause gout, can cause the flares. And so patients will, in frustration, start to take the medicine for lowering their uric acid, thinking that that will treat their gout, and end up with horrific and prolonged gout attacks because they are not using the treatment properly. So the two arms of the treatment of gout are very simple. Pain control is one arm, necessary and essential, but it doesn't treat the uric acid level. It treats the pain. Nobody wants to live in pain. You're not going to get a compliant patient if they're in pain. But that is separate and apart from treating the underlying problem, which is the elevated uric acid. So once you develop the gout attack in the context of your elevated uric acid, we then need to bring the elevated uric acid down. And how do we do that? With uric acid lowering agents. These are medications like allopurinol, febuxostat. Certain antihypertensive agents can be helpful in that regard. And what you want to do is bring the uric acid level down while keeping the patient as pain-free as possible. When you treat the uric acid level, you're going to potentially increase the patient's risk of having attacks, because when you lower the uric acid level, the crystals begin to dissolve. They come out of solution, they come out of crystals, go back into the blood, and then are excreted. And what happens is during that process, you can actually end up with gout attacks as the crystals move from one form to the other and out of the body. So when you're treating the uric acid, you want to have the patients on what you call prophylaxis. That means you give them medication daily in addition to the medication that lowers the uric acid, so that so you minimize their risk of having a gout attack while you treat the uric acid. And the agents we use for that are the same agents that you use to treat the gout attacks, but you use them in a different way. If the patient has no contraindications, the colchicine can be taken daily along with the uric acid lowering agents to reduce that risk while you're getting rid of while you're lowering the uric acid. You want to lower the uric acid to a level of 6 or below, and several months after you've achieved this, you can guarantee the patient that they will be pain-free, and gradually you can stop the uric acid prophylaxis. The uric acid lowering agents, if you lower the uric acid, you will actually, the tophi that we demonstrated, we saw earlier, will actually dissolve. And some of the tophi in the subcutaneous tissue and even in the joints can dissolve. You won't necessarily reverse all the damage, but you can certainly get the tophi to resolve. And you see it all the time. The patients tell you, "Doc, these are getting smaller." That's because they're being dissolved. So even a patient with advanced gout and bad gout can get good results, can get those deforming masses to resolve if he or she is treated properly. Now, in addition to the allopurinol and to the febuxostat, to the pills, there is IV medication you can give to actually help dissolve the crystals if it comes to uric acid, if it comes to that, if they don't tolerate the oral medication properly or adequately. And so basically, in summary, gout is a disease of elevated uric acid depositing in your body, causing you deformity, causing you inflammation, causing you pain. It is imminently treatable, and the benefits of treatment are actually prolonged a pain-free state. You can reduce and eliminate the gout attacks that you have if you are treated properly. The major barrier to treatment of gout is that the patients are not aware that they have two tasks. One, to lower their uric acid with daily medication such as allopurinol or febuxostat, which lowers the uric acid, and two, prophylactic medication to keep them pain-free on a daily basis so that while they are treated, they don't have the flare attacks of the gout. And thirdly, if they have an attack of the gout, their uric acid lowering agent should not be stopped. So most of the pain and the uncontrolled joint damage that you see with gout is just a misunderstanding of how to properly treat it and address it, and how to handle the different phases, from the chronic hyperuricemia in the context of gout attacks, to the acute attacks, to the vicious cycle of pain. All can be treated, but you just have to understand at every stage what needs to be done. And the major problem with gout is education. People don't understand how to treat it, so they don't get good results. Thank you.
We hope you've learned a lot from this edition of the Doctors Hospital Distinguished Lecture Series. Please join us in the Loudon Conference Center on Dowsville Street every third Thursday for the monthly health talks, where you can feel free to ask your questions. Isn't your health worth it?